welcome to our Research Matters event on prostate cancer. Thank you all everyone for braving the cold and maybe the first 10 minutes of the Matildas game to get here tonight. I want to start by acknowledging the Mawina people, the traditional custodians of the land on which we gather today, and pay my respects to Aboriginal elders past and present. So I'm Steph from the Royal Hobart Hospital Research Foundation. As many of you know, we provide funding to local researchers to improve the health and wellbeing of Tasmanians. So tonight's a great opportunity for us to show you how your donations are supporting groundbreaking research into a really significant disease that affects so many men. I'd like to thank Dr. Kelsie Raspin, Dr. Liesel Fitzgerald and Dr. Nick Davies who have volunteered their time to educate us on the most diagnosed cancer in Australia. Thank you guys. Thanks also to Josh for joining us as our MC tonight. I'd also like to thank Hobart Private Hospital for their support of tonight's event. I'd like to welcome the CEO of the Hobart Private Hospital, Catherine Berry, to the stage to share a few words with us tonight before we start. Thanks everyone.
Hi everyone, and thanks for coming. And I was just talking to Nick, having a bit of a moan about my perimenopausal heat wave that I'm having here, and just saying that we all talk about women's health, but how important it is for us to be highlighting the issues for men, and they're quite often not recognised well enough. From working in the hospital environment and with Nick as one of our urologists, prostate cancer is a big part of what we do at Hobart Private. And on top of that, I'm a board member of the Research Foundation, and I just think it's really important in Hobart, we're a small town, that we all work together to really improve the health of our community and look at ways that we can all participate and make a difference to the health of Tasmanians. And we had a similar talk here on dementia a couple of months ago, and it was absolutely fantastic, and really proud that I can be part of a foundation that works with researchers that can do so much and make such a difference. And the fact that you're all here on the night of the Matildas game, and I've just flown back from Sydney, so it's a little bit Matildas crazy in Sydney today, that you've come here and that you all see how important it is to talk about health and to talk about men's health, because it's something that gets sometimes swept under the carpet. So thank you so much for coming, and I hope you enjoy the presentation.
Welcome everyone, and thank you for coming. I'm Josh, as Steph mentioned before, and tonight we'll be taking a deep dive into prostate cancer. It's a disease that affects 1 in 6 males by the time they're 85 years old. Throughout the discussion, our expert panel here will be discussing the signs and symptoms of prostate cancer, how it's detected, what increases your risk of getting the disease, and some of the innovative treatments we're seeing. Before we start the conversation, I want to introduce you to the 3 people we're making up our expert panel tonight. Here on the right we have Dr. Kelsie Raspin. She's a postdoctoral research fellow in genetics and cancer at the Menzies Institute for Medical Research at the University of Tasmania. She was awarded her PhD in 2020 and has since become a successful early career researcher. Her research focuses on understanding the genetic changes that contribute to prostate cancer development and its progression to metastatic disease. This year, Kelsie was awarded the Royal Hobart Hospital Research Foundation's Major Project Grant for her study on precision care for men with prostate cancer. Kelsie, I look forward to hearing more about that later on in the evening. Next, I'd like to introduce Dr. Liesel Fitzgerald, who's in the middle. Dr. Fitzgerald earned her PhD in molecular genetics of familial prostate cancer from the University of Tasmania in 2007. After working overseas and interstate for several years, she returned to Tasmania in 2015, where her research now focuses on identifying genomic predictors that can be used in diagnosis, prognosis and treatment of prostate cancer. For example, Liesel has a research project funded by the foundation that focuses on developing a valuable Tasmanian clinical and genomic research for prostate cancer, genomic resource for prostate cancer research. We look forward to hearing more about that later in the night as well. And finally, there on the end, we have Dr. Nick Davies, a urological surgeon with an interest in prostate cancer. Nick trained and worked in Tasmania and Queensland, and now works as a consultant urologist at the Royal Hobart Hospital and operates privately at the Hobart Private and Calvary Hospital. He has a particular interest in minimally invasive surgery, which we'll touch on later in our talk as well. Now that we've met tonight's panel, let's launch into tonight's discussion. I'm going to begin by asking some questions, and then at the end of the talk we'll have a chance for those in the audience with questions to have that answered. It's not very often you have a chance to have a question answered by an expert researcher, so any questions you do have, please bring them forward, as there's no better time to get it answered than this. So Kelsie, the name of the disease tells us a lot, but can you explain to us all what prostate cancer is and how it forms?
Sure. So yes, you're right. The name says it all. So prostate cancer is cancer of the prostate, which is a male reproductive organ. So normally in the body, your cells grow, divide, and then die. So that's called cell turnover. And so that happens in the prostate as well. But sometimes when cancer arises, there's a particular something inside the cell goes wrong that causes the cell to not be able to die, which means that instead they continue to grow, they continue to proliferate, and that means that they grow uncontrollably.
Kelsie, can you tell us of the different types of prostate cancer?
Yes, there are. So there's low-grade and high-grade prostate cancer. So low-grade prostate cancer, as the name suggests, is more indolent, it's slow-growing. It normally has a low Gleason score. I'm sure you've probably all heard of that. It usually has a low PSA level, so PSA is prostate-specific antigen, and that is what the doctor detects in your blood whenever you go and have a blood test. And it doesn't necessarily need to be treated aggressively, so most often the doctor prescribes a wait-and-watch approach. Whereas a high-grade tumour has a high Gleason score. It normally has a high PSA level, so normally over 20. And it does have to be treated more aggressively, and sometimes those tumours can be treated aggressively, but they don't actually respond very well to treatment, or they become resistant, and that's when they can become metastatic, which means that they move to other sites outside of the prostate, such as the brain, bone, or the lymph nodes. But we will be discussing treatment later on today as well.
Is there one of those that's more common than the other one, or are they roughly similar?
They're roughly similar, yeah, but actually I'd probably say low grade would be more common, yeah.
Liesel, can you answer a couple of questions for us? Before we discuss the symptoms of the disease, I'm keen to understand what causes prostate cancer. Are there obvious risk factors? For example, like smoking increases the risk of getting lung cancer, obviously. Do we have a similar thing for prostate cancer?
No. So unlike a lot of other common cancers, for example, lung cancer, skin cancer, breast cancer, colorectal cancer, there aren't obvious strong environmental risks for prostate cancer. Instead, the risk factors include age. So the older you are, the more likely you are to get prostate cancer. Another one is race. So African American men are more likely to get prostate cancer than Caucasian men, and then Asian men tend to have lower rates of prostate cancer. And then one of the strongest risk factors is family history, or your genetics, your underlying genetics. And this is so strong in prostate cancer. Prostate cancer is actually the most, what we call, heritable cancer. So a lot of us think breast cancer is a very strong family familial disease, but in fact prostate cancer is more heritable than breast cancer. And for example, if you have a father or a brother, so a first degree relative with prostate cancer, your chances of getting it yourself are twice as likely at least than if you didn't have any relatives with prostate cancer. And this risk actually increases more and more the more relatives that you have with prostate cancer.
So it sounds like family history and genetics are incredibly important.
Yeah.
Which might not be too comforting for anyone who doesn't want to get it, but is there anything we can do as a man to try and reduce our risk of getting it?
Yeah, so unfortunately you can't change your genes. What you inherit, you inherited, and it is very important to know your family history. And I know men feel a little bit uncomfortable talking about their health, but it's really important to see if you can find out about your male relatives and who has prostate cancer. And then if you yourself have prostate cancer, it's also very important to tell your relatives, let them know, especially younger male relatives. And the GP so you can take this information to your GP and they can use it to determine what approach to take in terms of screening for prostate cancer. So for example, if you tell your GP that you've got a family history of prostate cancer and you don't have it yet yourself, they're likely to start screening you a little bit earlier because, like most other cancers, the earlier you detect cancer, the more likely you are to be able to cure it.
Nick, what are some of the common signs and symptoms of the disease that we should be looking out for, and when should we make an appointment with our GP?
It's a great question. Prostate cancer in general, I don't want to see people when they've got symptoms of the disease, because that normally means if you've got symptoms from prostate cancer, it's generally very advanced. A lot of men come to me with an elevated PSA, which is the blood test, and I say, oh, you could have prostate cancer, and they say, oh, it's okay, I don't have any symptoms, but that's the exact time we want to be diagnosing prostate cancer, in that lead time before any symptoms develop. It's important for men with urinary symptoms to know that the vast majority of urinary symptoms are not related to prostate cancer. That's normally related just to a benign overgrowth of the prostate, but it is often the thing that brings people to their GP because they're worried about prostate cancer. So it's nice to reassure them in that respect that prostate cancer doesn't typically cause symptoms. If it becomes quite advanced, the symptoms you can expect, you can get urinary symptoms, you can get blood in the urine, you can get fatigued, loss of weight and bone pain, but that's a very small percentage of men getting symptoms. So I really want to see them before that point, based on a screening blood test.
At what point should people start getting screened or start keeping an eye and thinking about getting screened?
It's a little bit controversial. Unfortunately, there was actually a bit of harm done by the US 14 years ago when they actually came out and said they thought that screening did more harm than good for prostate cancer. I think that in the current climate, I think that's been completely refuted. But there is that sort of reluctance among some in population, and including some medical professionals, to sort of not offer screening to all men. There are some very good guidelines now, so the Urologic Society, the Prostate Cancer Foundation of Australia and the NH and MRC guidelines are all in sync, and so we suggest men between the age of 50 and 70 should have PSA screening every couple of years. If the PSA is above 3, they should be referred for further testing. If it remains above 3 on a second test about 1 to 3 months later. If, as Liesel and Kelsie were saying, if you've got a strong family history, so 2 or 3 relatives, you can start screening at age 40. And if you've got 1 family relative with prostate cancer, you can start screening at 45.
What tests would the GP be carrying out to test if you do have prostate cancer?
Well, it's as simple as a blood test. So in those same guidelines that I mentioned, we're trying to get as many men to have screening as possible. We want them to have the blood test. And so we've even gone away and said, well, GPs don't have to do a rectal examination. And we want everybody to know that. So it's as simple as, you go to get your blood tested for your cholesterol or for potential diabetes or just your kidney function or whatever. And we just want people to write. We want the GPs to be writing on PSA for men in that 50 to 70 age bracket. You don't need to have an intimate examination up the bum. You don't have to have anything more than just that blood test. Because if that blood test is less than 3, we can say your risk of prostate cancer is really quite low. But if it's above 3, it doesn't mean you've got prostate cancer, but it does probably warrant further testing to try and rule it out, because we want to get it early because it's highly curable in that stage.
Thank you for ruling it out for some people. I'm sure there are many who are thankful they don't have to get there just yet. What happens if we are unlucky enough to get prostate cancer? Are there some types or grades of prostate cancer that are worse than others? When you're looking at it, we heard about the more aggressive form earlier.
Yeah, so prostate cancer is a spectrum, and every man is different. Every man has different treatments. Every man has a different sort of risk profile, and we sort of try and pigeonhole people into certain groups. But essentially we're looking at how aggressive the cells look under the microscope. So to diagnose prostate cancer, we need to do a biopsy, or I need to do a biopsy. You get a score based on that between 1 and 5. one being pretty non-aggressive, probably can just be watched safely without needing treatment, right through to more aggressive forms, 5, and everything in between. And then we also look at the PSA to inform what risk profile you've got, and also how much of the gland is involved by the cancer. And based on that, we can get a pretty good idea about, if the first question is, does this prostate cancer need treatment in this man? And second, based on the decisions that we've already got about the risk profile, what sort of treatment might be needed.
So moving on to treatments, Liesel, we've all heard that more men die with prostate cancer than because of it. What does this mean, and why, I guess, wouldn't we treat someone who we know has prostate cancer?
As both Kelsie and Nick have mentioned, we seem to have a spectrum of prostate cancer, and we have these forms that really are quite indolent. They're very slow growing, they're very unlikely to affect a man's health substantially, and there's a saying, you're more likely to die with and not from prostate cancer. And another factor to take into consideration is that some treatments that we use, some aggressive treatments, for example radiation therapy and radical prostatectomies, they actually can cause quite severe side effects in men, like sexual or bladder, bowel issues. And if a man has a very mild form of prostate cancer, he doesn't necessarily need to be treated, and he could in fact, after treatment, end up with worse quality of life due to treatment side effects. So it's very important to I guess, if you're not making the decision not to treat, still continue to monitor a man's disease. Again, this can be done with simple PSA tests regularly, and just have a watch and wait approach. But yes, not every man does need to be treated these days.
What does a less aggressive form look like? What are the life impacts that someone might have from that lower end of the scale cancer?
So I think there are a lot of psychological impacts. When someone says you have cancer, I know I would freak out, but the reality is there are very mild, indolent forms of cancer, and so I think quite often deciding whether to be treated or not doesn't just depend on the cancer itself, it also depends on psychologically how you can, I guess, cope with the fact that you are doing nothing about cancer, which we're not really trained to do historically. So yeah, I think there are psychological impacts that have to be considered as well.
John, I'll just say something to that. So that's exactly right. We call it active surveillance, and so a lot of that discussion with the diagnosis is not saying we're not treating it. It's often saying we don't need to treat it now. And so we watch this like a hawk. We watch it with PSAs, we watch it with MRIs, and often with repeat biopsies. And so we would expect that if this prostate cancer starts to act in a slightly aggressive manner, we will jump on it and treat it at that point without having to worry about it having already spread, because we have time to do that. And so that's what we coined this term active surveillance. We're actively watching it, and we will treat it if we need to, but we often don't need to do it now.
So when would you consider treating someone for prostate cancer? What are some of those triggers that you look for to jump in?
So the first one is what it looks like under the microscope. So we used to use something called the Gleason score, but that was quite confusing because the lowest score you could get was 6 out of 10. And so people thought, I've already got 6 out of 10, why are we watching that? So that's why we've gone to this 1 to 5 scale. So 2 and above, generally, we'd sort of say treat unless there are other factors. Men over the age of 70 will often watch the score 2. Score 1, we're generally watching just about everyone now, and we know that's very safe. The PSA comes into it. There are certain thresholds that we would set and say, look, as soon as the PSA gets above 10 or 15 or some other predefined threshold while we're watching a cancer or when we diagnose cancer, that's the point where we'd already say it needs to be treated. And then other features like, what it looks like on the MRI, or how much of the gland is involved, or is there any evidence that it might be just sending little roots outside the prostate. So they're all the things that said, well, this isn't one that should be watched, because at this point, we've probably been through the period where we can watch it. Now is the time to jump on it and treat it.
Can you run us through what some of the different treatment options are available?
So for localised cancer, this is cancer that we think is just confined to the prostate. The first option, as we've discussed, is active surveillance, which is watching it and treating it if we need to. What I do is surgery, so we can remove the prostate gland, so it's called a radical prostatectomy. So that involves removing the entire prostate, the seminal vesicles, and you get a free vasectomy with that. And then we have to reconstruct, put the bladder back onto the urethra, and then let the body heal. Sometimes we'll take the lymph nodes, which is the first point that the prostate cancer can spread to. And that surgery can be done, traditionally it was always done open, but now we're moving into minimally invasive approaches, and using a robot is the way we're sort of going. Most of Australia is going that way for various reasons, which we could probably talk about later. We favour that in younger men and men that have got a long time to live. If we can knock the prostate cancer on the head, you get over your surgery, you heal, and you should have a really good quality of life. Radiation is an option, and radiation and surgery are pretty much equivalent in terms of their cure rates. And so I can't sit here and say that surgery is better for everybody and radiation is not better, but there are cases where one is better than the other, and some men will put it to you and will say, look, you get to choose. There's not many cancers out there where the doctor will say you can choose your poison, you can choose your treatment, and men will make a decision based on what they prioritise with their quality of life and treatment. There are other treatments like brachytherapy, which is where we insert little seeds of radioactive activity into the prostate. And then there are some newer treatments, lasers and focal therapies, although they're quite experimental. So that's the whole gamut, and there's others that I haven't even mentioned, but that's the treatment options for localised prostate cancer. And then if the cancer has spread or it does spread after treatment, that's an ever-evolving field, and there's all sorts of hormonal treatments available to really make the cancer dormant, shrink it down, and often give really quite long-term cancer control.
Nick, you have a particular interest in minimally invasive surgery, as you said. Can you tell us a bit more about how that works and why it's important or better? So as I said, previously we used to do open radical prostatectomies, involved a cut from just above the pubic bone all the way up to the belly button. We were constrained a little bit because we're operating down in the pelvis. It's quite difficult to access the prostate. It's very deep. And so you're often operating with quite long instruments. The dexterity isn't all that good. You can only operate with a strainer. You can't get your hands in there to do it. And so there were some concerns that we weren't doing the best job with that. We're doing a good job, but you sort of didn't have that magnification. Using a robot has been a game changer. That has, there are $3 or $4 million machines. The surgeon will set up the robot, set up the arms. It's keyhole surgery, but I'm sitting in the corner operating a console like a video game, and the robot is doing what I tell it to do. So I'm controlling everything, but the robot with these articulated arms and magnified vision, it's like I'm operating right here with these little fine articulated arms. I can have a coffee and it takes out my tremor. It's amazing. And so, although the evidence says that the cancer outcomes are no different and the functional outcomes are no different, we certainly all feel that we can do a better surgery. We can almost see the nerves around the prostate and spare them. We can almost see the capsule to the cell and we can get around it. And it certainly is prolonging a lot of surgeons' life from an ergonomic perspective. The things where the robot is definitely better is much quicker recovery. I think quicker return of continence, a shorter duration of hospital stay and catheterisation, and a much lower risk of bleeding and complications associated with that, like needing a blood transfusion.
So yeah, that's something we can offer in Hobart now too.
Kelsie, you received foundation funding to conduct research into precision medicine and how this can be used to treat patients with prostate cancer. Can you explain what this phrase means and how it works for patients?
Yeah, sure. So as Nick just mentioned before, there are a few different treatment options that a man would have to decide upon when they were diagnosed with prostate cancer, but it's a largely one-size-fits-all approach, and it's not going to work in every single circumstance. So some people will have a response to treatment, some people will have a response for a short period of time, and then their cancer will return, whereas others may not have any response at all to their treatment. So we're now finding though that not all cancers of a particular type, so even prostate cancer, are genetically the same. And as Liesel mentioned, men have different risk genetically of prostate cancer. So analysing these genetic changes is now allowing us to match their most effective therapy. So we're able to choose treatment options that are more likely to work in every single circumstance, which will obviously increase a patient's survival and their longer term outcomes. So this is what we call precision medicine, and you may have heard of a different term, precision care or individualised medicine or targeted therapies. So precision medicine is delivering significant improvements in other cancers, so particularly breast and ovarian cancer. So you may have heard that women with mutations in genes called BRCA1 and BRCA2 are now eligible for PARP inhibitors, and they are a targeted therapy that target that particular mutation within her genes. So unfortunately, this is not the case for prostate cancer, and we're a little bit far behind in that men are not currently eligible for a precision medicine approach if they are diagnosed with prostate cancer. But this is why I've started my studies. So.
Yeah, so now we're going to hear from the researchers about some of their work and looking ahead how it might be able to be incorporated into current medical advice. So Kelsie, can you tell us a bit more about your study and how it will help people here in Tasmania in the future? And you've got some slides prepared.
So yeah, I received funding this year for 3 years from the foundation, and that's to initiate a new study called precision care for men with prostate cancer in Tasmania. It's a mouthful, but that's why we created the acronym, so PC for PCTAS. So this is, the first part of it is offering genetic testing to men diagnosed with high-grade prostate cancer. So we're currently recruiting Tasmanian men who have been diagnosed with high grade, so more of the higher Gleason scores or the higher ISUP grades that Nick was talking about. And we will then offer these men genetic testing in a research setting, so we will perform what we call whole genome sequencing. So as the name suggests, it's sequencing of your entire genome. And we will then pull out mutations in certain genes that we're interested in. So genes that we know have been associated with other types of cancers before, so what I mentioned before, the BRCA1 and BRCA2, that will be included in our search, but also other genes that we know that are involved in biological pathways within the prostate. So once we do that, we will use international guidelines to identify pathogenic or likely pathogenic mutations. So that means that these mutations are more likely to be causing prostate cancer in these particular participants. And we will then return these genetic results to our participants through the Tasmanian Clinical Genetics Service over at the Royal Hobart Hospital. So this first part of our study will basically be able to return a genetic result to more Tasmanian men who currently face limited treatment options. And this may mean that in the future they may be eligible for those targeted therapies such as PARP inhibitors that I spoke about previously. And obviously we're going through the Tasmanian Clinical Genetics Service, which means that we're actually testing in the real world the potential and feasibility of genetic testing here in the Tasmanian healthcare system. So the second part of my study is to do with consumer engagement. So we know that consumer engagement goes hand in hand, we know that moving towards more of a precision medicine or patient-centred healthcare system goes hand in hand with consumer engagement. And it really is paramount to understand people's expectations and perceptions of genetic testing if we want to implement this into the clinic in the future. So as I'm sure you're all aware, genetic testing may have a psychosocial impact on these patients, and they are really difficult to capture using administrative and clinical data, and they're much more easily captured using patient-reported outcome measures. So patient-reported outcome measures provide a valuable insight into a patient's experience, whether it be their experience of their diagnosis or their treatment, and it has been shown to have a positive impact in cancer clinical care. So if you follow that flow chart, we're currently undertaking a systematic review of the literature, which means that we're searching all of the literature that currently is out there about patient-reported outcome measures and genetic testing in the prostate, breast and ovarian cancer space. And that is to generate a list of the most important patient-reported outcome measures. And then we're also undertaking consumer focus groups, which means that we're talking to men who have been diagnosed with prostate cancer about their experience and then their perceptions, expectations and what genetic testing actually means to them. And then, as I said, these two different points will then be able to generate a list of patient-reported outcomes, which will then establish the opinion of experts through a series of questionnaires where the experts are asked to rate the items, the patient-reported outcome measures as least to most important. And these will be sent to patient and care advocates, researchers and clinicians as well. So then we'll undertake a meeting where we will review and confirm the final patient-reported outcome measures that we want to include in what we will call our core outcome set. And this core outcome set will guide national and international standards. So whenever a man is offered genetic testing in the clinic in the future, these are the core outcome measures that will be measured at the time. And that is all I have.
Thank you very much, Kelsie. And now we'll have Liesel. Liesel, you also received funding from the Foundation this year to develop a clinical and biased specimen resource to predict and improve treatment strategies for men living with prostate cancer. Can you tell us a bit more about that study and how it will benefit the health and wellbeing of Tasmanians?
My study is called Biomarkers to Improve Outcomes in Prostate Cancer, and as you saw from Kelsie's slide, we love an acronym because it's much easier to say, so it's actually called the BIOPIC study. And we've spoken a lot tonight about the fact that not everyone responds the same way to the same treatment. And we know that changes in our DNA, so genetic changes, influence how we respond to treatments. And this is not just prostate cancer treatments, this is also aspirin and Panadol, all sorts of treatments. So for example, if we had a group of men and they were all treated with radiation therapy, some of those men will respond really well. Some will respond at the start partially, but then the cancer will start growing again. And then some men won't respond at all. And if we look at that group of men again, some of these men might respond well to the treatment, but they've got very severe side effects from the radiation therapy, and it's so severe that they have to consider actually halting the treatment. And then there'll be other men that respond well and have no side effects whatsoever or very mild side effects. And so if we knew this information and what genetic changes influence treatment and how you respond to treatments, we could actually use this to tailor treatments specifically for men based on what genetic changes they do or don't have. So I'll just run you through a bit of an example. This is a group of Tasmanian men, and we know that these men have been treated with radiation therapy. We can gather their clinical information from doctors' records and hospital records, and we can work out of this group of men, some of them responded very well to the treatment and others didn't respond at all. And then if you can gather their genetic information, you can look at the group of men, for example, that responded to the treatment, and you can compare their DNA with the men that didn't respond and see if there are particular genetic changes that these men have that are actually helping them respond well to the treatment. And then you can do the same for the group of men that didn't respond. We can look at their genetics and we can see if they have particular changes in their DNA that these men don't have, and that are stopping them from responding well to the treatment. So once we know genetic changes that influence how men respond to treatment, we can actually take this information back to men before they're treated, and we can test their DNA and work out whether they're actually going to respond to radiation therapy or not. Because if they're not going to, it's not worth treating them with this therapy, and they can be treated with something else. For our biopic project, we're getting the clinical information from the Prostate Cancer Outcomes Registry, PCOR-TAS. And since 2015, PCOR-TAS have been trying to collect information from every single Tasmanian man diagnosed with prostate cancer. And they collect all their clinical information from their hospital records and doctors' records and store it in a database or registry which we can then access. And our study is going to all of the men that have been registered in the registry, and we're asking them if they can provide a blood, saliva or tumour sample so we can then use this to work out their genetic information. So the main aims of the study is to firstly identify genetic changes that influence how a man is going to respond to the treatment. Is he going to respond well or poorly? And then secondly, identify changes in his DNA that influence treatment side effects. Are they likely to have a lot of side effects or few side effects? And then we want to use this information. So a man presents with prostate cancer, we can test his DNA. If he's not going to respond to a treatment, we're not going to give it to him, we're going to give him a treatment that works and that will hopefully save lives. And then we're also going to see what spectrum of side effects are they going to have. Because if they're going to have side effects that are going to affect their quality of life, maybe we'll choose a different option. So it will increase men's quality of life as well. That's all. Thank you.
Thank you so much, Liesel and Kelsie, for sharing some more information about your projects that you've currently got going on. They sound excellent, and hopefully there's some exciting news coming from it soon. So now we're going to have some questions from the audience. So anyone there that's thought of a couple of questions about what they've heard from any of our three panellists, now's the time you can bring those forward. I just want to remind you that our panellists can't give out any specific medical advice. So please keep the questions general in nature, as they won't be able to do that. Kelsie's just just a coffee fit. She'll be back in a minute. So, were there any questions for Liesel or Nick to begin with?
Nick, Tony, my name, excuse me.
Hi, Tony.
I was diagnosed with prostate cancer about November 2021.
Yes.
And it wasn't until February 2022 that I had a TERF. Now I wondered why I didn't have the whole prostate removed. And it wasn't until November 2022 I was then sent to an oncologist and started treatment, and my PSA had gone up to 60 or something. I'm wondering whether it would have been different if the time frame had been somewhat different.
It is hard to comment. In general, prostate cancer, even the high risk and aggressive forms, are still thought to be relatively slow growing, and we generally do have a lot of time to treat them. It's more important to make the right decision rather than rush into the wrong decision for treatment, and delays of 3 or 6 months for prostate cancer treatment, unless it's already spread, generally don't affect things. This has normally been around for many years. It's hard to comment on specific circumstances, but generally we have time, from the diagnosis to the treatment. When the PSA is getting up above 20, that's when we start to worry about, even if we can't see any spread, Sometimes you can have small little deposits, and that's what makes that a high risk of prostate cancer.
Well, between February and November, it went up to 60.
Yeah.
Which is pretty high.
Yeah. Certainly the PSA can go up with prostate cancer, but other factors can be at play too. Yeah.
Is there a reason why you don't remove the whole lot?
The whole gland?
Yeah.
Yeah, generally we do. A TURP is to treat urinary symptoms, so that's a rebore to remove part of the prostate. That's not a treatment for cancer. That's a treatment for urinary symptoms or obstruction or other reasons, but not cancer. So it's not a treatment for cancer.
I just want to ask about are there any impediments at present on getting samples of DNA from people? So you can do all this linking. Is that automatically done in the hospital, for example, or do we have to come along and give a DNA sample?
So for our project, we write to men who have participated in the registry and then and ask them if they would like to be part of our study. And if they are, we have several options for getting DNA. One is they can come into a clinic, or we can organise, because we're recruiting men all across the state, so we do clinics up north as well, and so we can organise clinics for a blood test. If you're a bit squeamish and don't like giving blood, like myself, we also can offer a saliva test where we just send you a kit in the mail and you provide saliva. And then we also have a third option where you can just not provide blood or saliva. And if you've had a biopsy or a TURP or a radical prostatectomy, that tissue is stored in our pathology labs, and we really only have 2 major pathology labs in the state, and we can access the tumour samples and get DNA and RNA, the genetic information from there. But we understand a lot of men might be very sick when we're asking them to participate in the study, so we like to provide several options. And, yeah, so there are a variety of ways to get the information.
Have you found people are generally quite willing to help out with the study so far?
Yeah, we've had a really good response rate. It's traditionally, Tasmanians are very good at participating in local research, and we have some of the highest participation rates in the world for our studies. I think it probably depends when we approach the men. If you've just been diagnosed, your world's probably all in a bit upside down and a bit of a blur. So yeah, it'll be interesting. We're still trying to catch up, so it'll be interesting the closer we get to diagnosis what the response rates look like.
My name's David Roberts. I have actually 2 questions, if I may. The first question is a statement that a friend of mine made, and I'm not sure whether it was true or not. That statement was to the effect that if you got to be 100, every band would have prostate cancer. So that was the first one. But the next one was a bit more serious in that I have a son-in-law who has died of prostate cancer, and he has a daughter, and I wondered whether there are implications for females either in terms of what they might pick up or be susceptible to instead of prostate cancer, and then, you know, any progeny that they might have as well.
So for the first
question? It's probably not far off that first statement. So there was actually some autopsy studies done some time ago that found that about 80% of men at age 80 had some form of prostate cancer. And that just plays back to that fact that this low volume prostate cancer is very indolent. Almost everybody gets it with age. But it doesn't mean that, you know, obviously 80% of men at 80 aren't dying from prostate cancer. So,
Sure.
Yeah, 100% at 100, maybe not. There's always an exception to the rule, but it wouldn't be far off.
Yes, that's generally true.
It's that common, yeah.
In terms of the overlap, there are particular families where we see a high rate of both prostate cancer and breast cancer, and we know there are particular genes which, if they have mutations in those genes, they do increase the risk of both breast cancer and prostate cancer. And we've actually had a family that we've studied and recently published on where we knew what mutation was causing the breast cancer and the prostate cancer, and one man actually had both. He had both breast and prostate cancer. So it does happen. Generally, you would probably see a very strong aggregation of both breast and prostate cancer. So, for example, if your son-in-law's family, there's no other prostate cancer in his first-degree relatives or breast cancer, it's probably unlikely that it's going to cause cancers in his daughter. But if there is a strong family history of breast or ovarian and prostate cancer, then it's something that the daughter should probably be told, so in future years she can tell her GP just so they can start screening early.
Okay, thank you.
Yeah.
She's only 12 at the moment.
Right, yes.
I think it's a bit young.
Don't bother her with it yet. She's got a long time to go.
Do we have any more questions? Oh, sorry.
One. Obviously, I've got prostate cancer. I haven't heard from you. Do I expect to hear from you, or should I approach you about going to a study?
Yes, so we are up to 2020. We're recruiting 2020 individuals at the moment. So if you are in the registry, expect a letter soon, and would love to hear from you.
Yep.
A few years ago, my friend told me that regular ejaculation can help prevent prostate cancer. Do you think that's at all likely?
Probably not. There's some studies out there for a whole lot of things. I mean, it was also postulated maybe vasectomy had some impact on prostate cancer risk, but probably not. I think we're talking absolute minutiae for these sorts of things. Number of ejaculations, vasectomy, certain medications. It's all, they're less than 1% combined, and you're dealing with family history and age is the two biggest. The other 99%. So, I don't let it influence any decisions.
Any other questions to come? All good. Well, thank you very much for coming here tonight, guys. I'd like to thank you all for attending. This is part of a series that the Royal Hobart Hospital Research Foundation has been running, so if there are more in the future, please I encourage you to attend. Thank you, Kelsie, Liesel and Nick, who generously gave their time to be here with us. The Royal Hobart Hospital Research Foundation has a wonderful reputation for funding innovative research to create better health outcomes for Tasmanians. As you heard tonight, the Foundation funds innovative research into this disease and so many others, but they need the support of our community to keep funding projects. So if you feel inspired by tonight's discussion, you can donate online at www.rhhresearchfoundation.org. Thank you again for attending, and we look forward to seeing you all again at an event sometime in the future soon. Thank you.